We're good. Go ahead.
Here we go. She is a practicing obstetrician gynecologist and a researcher at UCSF. I'm very lucky to have heard her a couple of times. And before I hand it over to her, in conversations, she really wanted to remind all of us that even though we're going to be talking about contraceptive choices and how it can affect our broader choice making, to remember that we can't lose sight of the structural issues that underpin decision making in general. It's hard for someone to think about pregnancy or HIV or preventing them or PrEP or contraception if they are not able to house themselves or eat or take care of kids. And so really to remember that even the best products are useless when structural issues are not in our sight. So with that, I'm very excited to hand it over to you, Dominika. Thank you very much.
Thank you so much. I'm going to share my slides. Can you all see those?
It looks great.
Great. So again, thank you so much, Jim and Manju, for having me, and I'm really glad to be with all of you today. As Manju mentioned, I'm an obstetrician, gynecologist, and family planning provider, and a PrEP provider based here in San Francisco at San Francisco General Hospital. I have to be honest with you, it is very early in the morning here, but I promise you it is not dampening my enthusiasm to be with all of you, and I'm really looking forward to the discussion after. When Jim invited me to join this presentation, I was really honored because it's such an exciting time in conversations about HIV and PrEP right now. And as I said, I'm going to give some brief slides, but I'm really looking forward to the discussion afterwards. Part of my excitement stems from the fact that we finally have real choices in HIV prevention to talk about, with more on the horizon. Many of you and I have been talking about choices now for years, but those conversations felt really constrained in the past by limited options. This graph is probably familiar to many of you. It's commonly cited to show how in the field of contraception, increasing the variety or method mix of contraceptives increases utilization. You can see how methods can increase on the x-axis, contraceptive prevalence or use also increases on the y-axis. Not surprisingly, more diverse methods meet the needs of more diverse users. This webinar series, The Choice Agenda, seems to really center us on this question. Have we arrived? Do more methods guarantee choice? And are we meeting the needs of more people? So I'd argue that lessons learned from contraception would caution that we haven't. Long-acting reversible contraceptive methods, or LARC, as I'll be referring to today, which include IUDs and implants, were early on seen as a panacea for family planning. These methods are extremely effective, resulting in near perfect adherence. They have a generally acceptable side effect profile, although that obviously depends on specific individuals' users' needs and preferences. They're reversible, they're cost effective. And because of these attributes, there was widespread public health campaigns that were focused on LARC in the United States and worldwide. These campaigns, which many of you are probably familiar with, emphasized LARC first for contraception. And they recommended that LARC above first and above other contraceptives based on their superior effectiveness. In these campaigns, specific populations were often highlighted as ideal LARC candidates because of an assumed inability to adhere to user-dependent methods. For example, young people, poor people, people with mental illness, people with substance use disorders, people who are experiencing incarceration. All of these populations were in some ways, quote unquote, targeted for LARCs. To make a long story short, these campaigns backfired, resulting in dissatisfaction with methods, discontinuation, and well-founded distrust of providers and clinics. People had negative impacts on their future healthcare interactions and profound medical distrust that we continue to face the consequences of today. So I'd like to pause for a moment. If you're wondering to yourself, is it really such a big deal to put an implant in a teenager's arm so they can't get pregnant? Or maybe you're wondering, isn't it a good thing to make sure that people using drugs can't get pregnant until their substance use disorder is adequately treated? Or let's bring it back to HIV prevention. Maybe you could replace either of those scenarios with PrEP. Isn't it a good thing for either of those groups who may struggle with the daily pill adherence to get on long-acting PrEP? I think I'd respond and say, sure, for individuals who want and consent to a long-acting prevention method, by all means. And for those individuals who don't, when we subtly or sometimes overtly pressure people into using methods, we are effectively saying one thing: we don't trust you. We don't trust you to know your own body, to know how to take care of yourself. In fact, what we're really saying is that we know better than you, so much that we're going to take away your bodily autonomy. I'm first and foremost a clinician, and as a clinician, I can assure you that there is no better way to alienate somebody from care forever than to meet them for 10 minutes and then tell them that you know better than them. And when that happens to entire communities or groups of people, those communities and groups hold those stories of how disrespected they felt and how distrustful they continue to feel for years to come. So what can that pressured use look like? Here's a study that was conducted at a large reproductive health conference that's similar to AIDS 2022 or CROI, where clinicians were asked to watch videos of different patients, and they were asked how they would counsel about contraception. Providers were more likely to recommend LARCs to poor women who were Black or Latina, and more likely to recommend LARCs to poor white women than to middle-class white women. This study really demonstrated how racism and classism influence provider practices. There are many, many, many other qualitative studies that demonstrate how Black and Latina individuals perceive subtle provider preferences. And these not only negatively affect contraceptive use, but also people's future healthcare experiences. One of the more subtle ways that implicit pressure comes up is in counseling. Specifically, tiered effectiveness was an approach to counseling that was highly encouraged. In fact, that was how I was trained to talk about contraception. In tiered effectiveness counseling, providers and counselors are taught to counsel potential users almost exclusively about the effectiveness of a method, prioritizing effectiveness above all other characteristics. You can see here, there's an example of a job aid that uses tiered effectiveness approach. And you can see how there's exclusive focus on method effectiveness in counseling. Here, what we're effectively telling people is that they should make their decisions only on method effectiveness and nothing else. We'll come back to this concept again in a minute, so please hold on to this idea of tiered effectiveness for a few minutes. Users also report how provider biases affect their access to removal of methods and affect their relationships with providers. This is a qualitative study that I think about every single time somebody asks me to remove their IUD. One patient said, "My provider was really hesitant to remove the IUD. She kept telling me, well, we should wait 3 more months and see if your symptoms have worsened." And I waited 3 more months and she's like, well, you should wait some more. And I'm like, no, so take it out or I'm going to a different doctor. In the same study, another respondent described, I don't know if it makes them, the providers, look bad if you have an IUD removed. I don't know if they have some chart somewhere, like a contest board in the break room. These stories come clearly much farther down the implementation path from where we are today with PrEP. But I think they provide an important cautionary tale as the family planning community is now playing catch up to rebuild trust with communities, after not only exclusively emphasizing the importance of effectiveness, but also pressuring users into using methods based on provider biases and discriminatory practices around who needs rather than who wants longer acting methods. As many of you saw at CROI, the REACH study demonstrated how similar to contraception, effectiveness is not the only variable that users care about when they're selecting a method. In this study, just as a reminder, after users were randomized to an intravaginal ring or to pills, they then switched to the other method, and then users finally got to pick the method that they wanted to continue. Interestingly, 67% of users chose the vaginal ring, demonstrating how effectiveness is not the only or even the primary characteristic that users might consider when choosing a method. That's really consistent with what you all said in the poll this morning. So I'm going to transition now into hopefully talking about some more concrete ideas about how we translate some of these lessons into care practices. I asked you earlier to hold on to that concept of that counseling approach of tiered effectiveness when you counsel about a method based on its effectiveness. Here is something in contrast. On the left-hand side of your screen, you'll see a somewhat blurry and microscopic, sorry about that, low-tech chart for contraception that offers a more person-centered approach to counseling, I think. It includes information about effectiveness, as well as other characteristics that users frequently care about, how the method's used, side effects. So the user can then finally identify what characteristics matter most to them, and then they can compare methods. I wanted to highlight for a moment menstrual side effects, which you may or may not be able to see in that list of characteristics on the left. You might wonder why menstrual characteristics are there if you're not frequently prescribing contraception. Well, it turns out that one of the main side effects that people identify that drives their decision to stop or change a contraceptive method is due to changes in their menstrual bleeding. One thing we've learned from contraceptive research is that while some people may see lightening or stopping of their periods as a good thing, for other people, they want to see a period every single week. I'm really not trying to drag you into the weeds of contraceptive counseling or menstrual bleeding as a side effect, but what I wanted to do is highlight that we can't assume what some people feel is a negative side effect applies to everybody. Other people might experience that side effect as a positive one. So what we need to do is to share information without inserting our own biases, values, and preferences, and explore with users how they will feel about that side effect, good or bad, to help them make a decision that's right for them. Electronic decision support tools can provide this information in more interactive ways, both for contraception, as you can see here, as well as for HIV prevention. Decision support tools can be particularly helpful because they can take the burden off of busy healthcare workers and counselors and can provide consistent information to users. Nevertheless, clinicians and counselors still hold a ton of power and influence. And so I wanted to take a moment to dive into thinking specifically about how we counsel, particularly in the context of PrEP as the method mix expands. So I'm going to take a big picture view for a second and zoom out and think very generally about counseling. When we think about that, we might think about two poles to counseling approaches. One that you can see on the left, where a counselor or a clinician lists all the methods and provides objective information about each one. It's like a menu of options that you could imagine. The counselor then takes a back seat as the patient or the user makes a selection without any input from the counselor. That might be defined as a consumerist-driven approach. That's in contrast to directive counseling, where the counselor prioritizes certain methods based on certain characteristics. Tiered effectiveness is the classic example, which prioritizes effectiveness. This type of counseling is rooted in the provider's preferences or assumptions about the user's priorities. So shared decision-making, as many of you are probably familiar, is often seen as something in between. Here, the provider brings our expertise in objective data on various methods, and then the user brings their expertise on their own priorities and preferences. Then together, the patient and the provider, or the user and the provider, engage in a discussion to support the user in identifying a method that best meets their needs. This method, at least in contraception, is associated with higher satisfaction with decision-making. And while it might not be best for everybody, it provides a starting point for person-centered counseling. So many of you might be thinking, what does that look like in practice? The first step of shared decision-making is trust building. This can be as simple as developing rapport, but it can also include exploring patients' prior experiences and explicitly committing to trying to uplift their preferences and their goals. Then when we explore preferences, the counselor can be as expansive as possible, trying to avoid the siloing of healthcare that we know so frequently happens. One example is for people who can become pregnant, explore their reproductive goals and how they may influence their decision-making about PrEP. The counselor then provides information that's evidence-based and includes clear and balanced information about side effects and benefits. Then the magic happens, the shared decision-making happens, where there's a conversation about matching evidence-based information with users' priorities and preferences. Finally, what's really critical is that the counselor leaves an open door for changes in plans and priorities. This might seem like a time-consuming process, and to be totally honest, it absolutely is. But this process can be done not only by clinicians, but also by trained counselors, health workers, peer educators, and then providers can reinforce those concepts in more brief interactions. I want to take a step back for a moment again to highlight some of the critical actors that informed family planning shift to this more person-centered counseling and provision of services. Reproductive justice activists have been critical in identifying the problematic and discriminatory ways in which our medical community has provided reproductive health services, including contraception and long-acting reversible contraceptive methods, or LARCs. In 1994, a group of Black women in the United States developed the Reproductive Justice Framework. This was in response to the reproductive oppressions that Black women were experiencing, and they highlighted how people deserve the right to self-determine if, when, and how they become pregnant, if, when, and how they give birth, and parents. Reproductive justice moves beyond advocacy for reproductive rights to advocating for a more moral and socially just approach to broadly promoting reproductive freedoms, particularly among historically marginalized groups. Many of you are familiar with Sister Love, an Atlanta-based reproductive justice organization. They've been a leader in expanding reproductive justice to incorporate sexual justice, explicitly identifying HIV prevention and PrEP as part of sexual and reproductive health. They've recognized the right to sexual pleasure, how it must be free from stigma, shame, and narratives that are focused on risk, quote unquote. So when we listen to these reproductive justice advocates and we apply those concepts to our shared decision-making counseling sessions with users, we have the opportunity to address some of that mistrust that I mentioned earlier. Specifically, when we apply a sexual and reproductive justice lens to PrEP, we have to consider how we can acknowledge the historical and social context of PrEP. For example, we can acknowledge how our research communities excluded many groups in early trials. We have to acknowledge individuals' lived experience, including potentially being pressured into or even excluded from other types of prevention methods. We have to describe what PrEP is, and really specifically what it is not. For example, we have to acknowledge that a given method likely won't be perfect for any given individual. We also have to expand method access and to respect the decisions of those who may choose to not use or discontinue PrEP. And we always have to continue to maintain our focus on meeting each individual's HIV prevention needs and goals. Sexual and reproductive justice highlight the importance of acknowledging context. And we can do that broadly, as we just described in relationship to research. We can also do that, though, locally for each individual user. When we think about what people bring into their healthcare visits for HIV prevention, and particularly when we center those individuals who are traditionally excluded from care, we know that people bring with them experiences of trauma, ranging from individual experiences to collective, all of three of the circles that you see on this screen. As people who work in healthcare, we have to acknowledge how specifically healthcare experiences can cause trauma. And even if we didn't participate in those specific events, our actions in the healthcare setting can be triggering. There are so many different types of triggers in healthcare environments, some of which are listed on your screen. And I wanted to highlight specifically the role of choice or lack of choice, because it is so directly related to the ways that we counsel about PrEP. To be much more concrete and succinct, I wanted to share with you a quote from a community advisory board member that I worked with in San Francisco. She had experienced homelessness during her pregnancy, and she had had a substance use disorder. She said, and this was again in response to ask a question about how would you give advice to healthcare providers and counselors? She said, don't try to push anything. If someone doesn't agree and you push it, they will completely shut down about anything you have to say afterwards. Pretty much sums it up. So how can we respond and proceed? I think trauma-informed care offers some principles to guide our healthcare systems, as well as all of us who are actors in those systems, how to care for and rebuild trust with particular patients and clients who have experienced mistreatment and have really well-founded distrust of our systems. This approach ranges from ensuring our systems welcome people back into care rather than asking them where they've been. We can use inclusive language, and we can ensure that we are always offering choices. Sean Gingrite pushes that thinking even further and highlights how trauma-informed care can be too focused on deficits. Instead, he encourages healthcare systems to focus on strengths and wellness, which again, when we think about in the context of PrEP, might be another way of helping us shift from risk-based thinking to wellness-based thinking in our conversations about PrEP. So I'm going to take us back to HIV prevention now. And when we think about that and the many discussions people are having about these PrEP journeys or people's decision-making processes and their experiences of how they start and continue or discontinue PrEP. In those journeys, we know that users will have starts and stops of their PrEP. If we offer PrEP in a way that is triggering, if we offer it in a way that's focused on our own priorities rather than listening to and uplifting those patients' and clients' preferences, then
you can go upstairs if you want. I'm done in there.
That journey can end abruptly and alienate people from care. So I'm going to wrap up by imagining what a PrEP journey could look like. It might look like somebody who's in the community and has access to strength-based community messaging about PrEP. Then people could access a healing-centered clinic or other type of PrEP access point that provides HIV prevention and where they can be counseled using shared decision-making. They then may decide to start PrEP, or they might not decide to start PrEP, or any other HIV prevention method. They then may stop and feel encouraged to come back again for further discussions. In turn, the goal over time is people's retention in care and rebuilding the trust in the healthcare system as a place to meet people's goals and priorities. In addition, when we think about that optimal HIV prevention journey, as Manju mentioned in the beginning, we have to acknowledge what research has so clearly demonstrated. that social and structural determinants of health drive so many HIV diagnoses. We know that, and patients and clients and users know that. So when a patient or client says, as I so often hear in San Francisco, I don't need PrEP, just get me housing, and then everything else will fall into place. We have to listen to those statements and advocate for those structural forms of HIV prevention along with our biomedical methods. Part of the choice agenda has to be acknowledging that so many people's choices are severely constrained by social and structural determinants. Without addressing those, the choice conversation really is incomplete. So while that PrEP journey might be idealized, there are tremendous barriers to reaching that state. And there are so many tremendous barriers to reaching that state. We can begin by collecting data. As I wrap up, I wanted to ask each of us to think about and ask if the research that's happening right now, does it reflect our values? And how are we measuring success? Is it in the HIV cases that we prevent? Is it in PrEP initiation, PrEP continuation? I'd argue, and I'm guessing that many of you would argue, that all of those are important. And I'd also argue that we limit ourselves when we focus just on those endpoints. We have to couple those outcomes with patient-reported performance measures. This is an example of one that's been tested and will soon be widely adopted in the field of family planning in the United States. You could imagine what it would look like to apply PrEP provision, as I annotated on the slide. These patient-reported outcomes don't have to be arduous, but they can be a simple balancing measure to ensure that the ways that we are offering new HIV prevention options are person-centered, trauma-informed, and supporting people's long-term engagement in healthcare. So with that, I'm gonna end, and I appreciate all of you very much. I also really wanted to thank Jim for inviting me to specifically acknowledge the sexual and reproductive justice organizations and advocates, patients and clients who have taken the time to teach me. And particularly, I wanted to acknowledge the family planning community, many of whom are under attack right now for providing medically informed options and choice. And I really look forward to our discussion. Thank you.
Thank you so much, Nika. What a beautiful talk. And we have over 15 minutes now for questions and conversation. I know I have some questions, and I'm sure Manju does. But let's see if there's anyone who would like to raise their hand and ask a question. I see somebody. Thank you, Nita. Go ahead, ask your question.
Thank you very much. That was really an excellent talk and very inspiring. So I have a comment and a question. The one is that as somebody who's been in the research field for over a decade, how do we as researchers unlearn our own decision-making? Because I loved your shared decision-making model. But how do we unlearn for ourselves in terms of choices we make when we engage communities, when we accept protocols, and unlearn as researchers, as funders and sponsors? Because in my view, only in that process can we then encourage and counsel and ensure participants, communities, lovers, partners, children make those choices. So for me, it's a lot of unlearning, starting with myself. So that's my question, but excellent talk. Thank you.
I so love that comment and that question. I think I'll start with humility and saying that's a really hard question and so important that we all reflect on. I mean, I think it really starts with pausing and listening to communities that have really been trying to speak up and have been speaking up for a long time. How do we do that? I mean, I think that can happen at the very local level of making sure that we are asking questions, listening to responses, and then incorporating them into our next research questions. And really, I think what I appreciate about your question is it really stems from the entire structure. You know, there is a strong movement now to incorporate, for example, community advisory boards into research projects. and how to do that in a real way where there's community advisory boards and those client accountability boards have real power means that we have to change the structures in which we're doing research. That type of research, that partnership with communities is on a different timeline, for example, than so many NIH grants or other grants. And empowering and allowing ourselves to modify our research or completely change our research question when we get advice from community members is a very different process than the way most of us write grants and structure our research questions. So I think that's one additional piece. And then I think the last piece is just a tremendous amount of humility as we go through the research process. One other kind of critical piece, I think, is always including a qualitative component in our trials to really unpack the findings that we're having and make sure that we weigh those findings just as critically and as importantly as the quantitative findings. And there's so much work to be done, starting first and foremost from recognizing how we as a research community have excluded so many people for so long and not listened to our communities. When we reflect on that, it's really humbling. And some people have started to talk about, what is a trauma-informed approach to research? Certainly our structures and our funding mechanisms do not support that. So we have a long way to go.
Thank you very much. And so my last comment, sorry, Jim, is the NIH has asked for information, the RFI, which is due on the 1st of August. And I think I strongly recommend, there's 156 people here who are really major role players, contribute some of your findings and your work into that discussion document so that we can change the way we do our research, having learned lessons. Thank you.
Thanks, Nita, for the question and comment, and thanks so much, Dominika, for that. And if you're not already, everyone, there's great discussion happening, really commenting on this issue of meaningful community engagement, but also from Chelsea about how we're looking at metrics. But there is a question here from Barbara. And the question is, how do you handle retention in PrEP care when many people on PrEP may need that prevention method only intermittently as their situation changes?
That's such a great question. And I think that is really about structuring our PrEP care and our PrEP services in a way that meet people's needs. I really work in a clinical environment that sounds, Barbara, very consistent with what you're talking about. People want to use PrEP very intermittently. And how do we make the services that we're providing relevant and important and make our place a place that feels worth coming back to for ongoing services so that when people are ready to restart PrEP, if they're ready to restart PrEP, they come back to us. We do that by providing a lot of wraparound services and recognizing that and really trying to break down our silos in healthcare, saying that this is just about PrEP. No, this is about sexual and reproductive health services in general. I have to say I work with reproductive age people, many of whom are getting pregnant or trying to avoid pregnancy or trying to end their pregnancy. And that provides a lot of kind of ongoing desire for engagement with healthcare services. And we integrate our PrEP services into that while also trying to address people's housing and food and mental health and substance use needs. So trying to really, again, make sure that our PrEP services are not isolated from the rest, I think is a critical way of allowing people to identify their priorities and help us kind of work through those. And then somewhere in the priority list, PrEP and HIV prevention often come to the top. And I'll have to say, I'm often surprised by when that happens. And if someone comes in with one complaint or discussion or thing that they want to focus on, how PrEP actually seems to bubble up as long as you kind of listen to people and hear and address what their primary concern is first.
Thank you, Nita. Thanks for that great question. There's a really great, I have a question and I want to start with a comment that Diantha made in the chat, which helps inform my question. just reminding us all that the choices that people make, and in this context, the choices of people who could get pregnant making around contraception are not static, and they change over their life course. And we expect this. It's the same thing for people living who want a version of PrEP, that choices can change. And so the whole point of having a wide array of choices. And I really love, Nika, how you've really talked at the provider, at the level of engagement with communities and people seeking services, how to best meet their needs. But there's this sort of upstream thing that's happening in our field, where the field itself is prioritizing efficacy over everything. The funders and the research establishment don't seem to be listening. We've been talking about choice for quite some time. We've been saying that we need things that are short acting, to the point, to the other point about, to Barbara's point, right? Like, not everyone, they're intermittent users. They don't want something necessarily in their body for years at a time. So do you have any advice on how we can better engage upstream funders, research, the research establishment, where the research agenda is created and driven, to make our case that we need options and choices that aren't necessarily more efficacious than long-acting cabotegravir, or more efficacious than an implant that stays in your body for a year or more. Any advice on what we can do to help our pleas for broader choices at that level be heard and listened to? I know it's not an easy question.
No, it is not an easy question coming from a group of extremely seasoned advocates. But I think it's using those same. I mean, I think about in family planning, how has the field shifted, and it has been a slow and steady grind. Starting with advocates, and really starting with, I have to highlight again, the reproductive justice advocates, who from the beginning really have continued to voice people's stories. I think the storytelling is one of the most powerful ways, ironically, within the family planning community. Even when talking to funders and researchers who are always going to say that's anecdotal, stories still are what grab us. And we hear those stories, and then we contextualize those with data. So I think it's those two pieces together. It's, again, I think what continued to uplift and kind of propel reproductive justice's advocates' messages forward was strong qualitative data at national conferences, webinars like this, conversation, and then coupling that with some of the more detailed and challenging to read patient-reported outcomes that really coupled the qualitative with quantitative data. I think Chelsea, I saw in the chat, asked for some references, and I can send those out afterwards. But there was this kind of parallel arm that was, to be honest, I think at the beginning quite hard to fund, but series of researchers who were really diving into measures and metrics to quantitatively describe people's experiences. And that also helped move the field forward. I think the last piece is really helping funders and organizations do some values clarification about what is this really about, and what is this about the short term, or is this about long-term care engagement? I think when you really sit down with individual people, they will be able to identify that our goal is more longer term. And then when you kind of identify those champions, then there starts to be change, but it certainly is slow. And I really appreciate how this group in particular is moving that agenda forward.
Thanks so much for that. We have only a few more minutes left, and I want to ask if anybody wants to put their hand up and ask a question directly. And maybe as people are thinking of their thoughts, I want to build a little bit on what you just said and what Jim asked. And these conversations are all bubbling right now. And I was part of a conversation recently with a mixed group of folks, including clinicians, researchers, and statisticians. And one of the issues put forth was that it was unethical not to provide a hierarchy of new tools when the efficacy is so different. And so efficacy was really being highlighted as what drove the ethics of this. I wonder if there's an example very specific example you can give us from contraception, or a paper we can read to really help us shift that thinking when ethics is raised as so important, because the efficacy is so different and it's about HIV prevention.
I think I can't think of a specific paper off of the top of my head, but I think, it's really important to say to people that it's not like we're trying to hide the efficacy and effectiveness. It's about making sure that we're providing balanced information, right? And ensuring that we not only offer information, but elicit what people care about, and then try to address those needs and preferences. When you think about the ways that these different methods are used, they are dramatically different. And in the field of contraception and I also in the field of HIV prevention, you'll have people walk into a room and say, there is no way that I'm going to inject something into my body, or there is no way that I'm going to put something into my vagina. I mean, people have very strong beliefs that you could spend hours trying to talk them into something. And it's just, we need to start from that framework of hearing that, and then within that context, discussing kind of options and preferences and values. Again, offering information, but making sure that the information that we offer is diverse. I will say that I think it's been really interesting to think about, for example, how we do research ethically in this context, in the setting of different effectiveness of methods. In the United States, for example, we've shied away at this point from doing randomized trials because the idea has been that people, well, actually, even not the idea, people have tried to enroll people in randomized trials and people won't enroll because their preferences are so strong and fixed. They don't want to be randomized to a contraceptive method. So I think that in some ways actually moved our field forward to recognize that people's preferences are strong, and we need to listen to those in order to ethically do research and allow us to then explore what those preferences and decision-making processes are, and then think about how to do trials in that context. I see a lot of people have their hands up, so I'm going to
Yes.
Yeah.
Thank you so much for that. So I'm going to ask, we have two people with their hands up. I'm going to ask both of them to say their questions, and so you can take them both. So we have Aditi, I'm sorry if I'm not saying your name right, and Sharon. So maybe you want to go in that order?
Yeah. Hi, my name is Aditi, and I am a pharmacist by training. And I was wondering how, pharmacists can be more informed about these practices. I think we're somewhere along the chain, but not really in there. So that's my question. Thank you.
Can I answer that really quickly? I love that question. And I think it really starts with pharmacists are one of the key people that people get their health information from. And so focusing on counseling approaches, focusing on pharmacists getting counseling in shared decision-making feels like a critical first step. And thank you so much for your question and the work that you do.
And so thank you. I very much agree about pharmacists, but thank you, Nika, for yet another fantastic presentation. Even though I've heard you multiple times, I learned something new each time. But I guess my comment was also to Manju, which is when I hear people raise this specter of ethics, it's just hiding behind the patriarchal hierarchy to say, I know better what you need than you do, little person, because of course you should use the most effective product. And so I think we need to unmask some of the patriarchal comments that are made in the name of ethics, because what's ethical is to allow people to choose for themselves what works for their lives. And I think we need to call out the patriarchal I'm going to tell you what's best for you, because this is absolutely widespread within the FDA, within funding organizations, between implementing organizations. So I think we need a much stronger voice, where you don't think we should have had to have a voice to call out the patriarchal attitudes about what women need and what men need.
Thank you for that, Sharon. You're getting a number of bravos in the chat, and I'm sure plenty of others who are thinking it or raising their hand in real life. I see I did mention we're going to probably go over a couple minutes, not too much longer. We want to capture some questions. I want to get to something in the chat around cost effectiveness, but I want to honor the hand that's up, and Homira, again, excuse me if I've said it wrong, but please go ahead and ask your question as briefly as you can.
Yeah, that was so this is very interesting because at Conrad, we've done a number of discrete choice experiments. And one thing that does come up is that effectiveness is very important. And in fact, when we did another survey, we had to remove that in order to see preferences for other attributes. So I think while it's not the only thing, it is very important to, a lot of the population. And also this idea of effectiveness, it's hard for, I think, a lot of people to even understand, with HIV prevention products, what is the standard level and what they're looking for, because people want something that's 99%, 100% effective. So when we're talking about this, I think there's nuances of the products, what people understand, what something works, what that means to them, amongst all the other attributes that I think are really important in making that decision of choice of what product they want to use.
I 100% agree. For many people, effectiveness is incredibly important. And I also think that there is a difference in terms of the hypothetical and when in reality, when faced with the opportunity of actually getting the shot or actually getting the implant or the IUD, how those decisions can change. And so there's a really important opportunity to couple those discrete choice experiments with implementation research that's showing us how people are actually acting in that moment and what decisions they're making. Because anecdotally, I've had so many counseling sessions with patients who or users who describe their plan to do one thing, and then in the moment, things change. And so just leaving lots of space to see how we translate those discrete choice experiments into implementation. And I just, again, to reiterate, I completely agree with you. For many, many, many people, effectiveness is really important. And it is contextualized by other decision making as well. And what we just see in terms of funders is how overpowering that view is. And that is why I think it's so critical to uplift these other perspectives as well.
Thank you. I had mentioned I wanted to pull something out from the chat that Corey Bloom, a fellow Chicagoan, Dr. Corey Bloom, a fellow Chicagoan, put in there. And she says, it seems like funders are interested in making and saving money, more money, as well as efficacy, right? So is there a way to use our messaging to talk about cost effectiveness that would also promote choice at the same time?
Yeah, I think that's really about helping people make decisions that are right for them. That is cost effective. And good counseling, providing important information that helps people make a decision that works for their needs and goals, will help people use the method. And therefore, that is oftentimes cost effective. I don't have the specific data on that, but in contraception, it's certainly been shown that if you can help people find a method that is right for them and that therefore they choose to decide to take, that can that ultimately leads in cost effectiveness.
Thank you so much for that, Nika. And I see we are now a little bit past the hour. I'm gonna see if my wonderful co-moderator has any closing comments or thoughts before we wrap up. Of course, we'll ask you, Nika, for a closing comment. If we were gonna take anything away from today's talk, what would we take away? But I'm gonna first turn it over to Manju.
Really, just to thank you so much. Like Sharon said, I've heard you a few times, and I learned something new every single time. And just to ask if you're open to getting direct questions, because I'm seeing a lot of private questions coming in. That's fantastic. Thank you so much for that. And again, just thank you so much. And back to you, Jim.
I want to just echo the thanks. I mean, I couldn't think of a better way to kick off this Choice Agenda project, our hot series of monthly webinars, than with you, Nika. You know, I feel like I've been chasing you down for several years. I remember seeing you at the MTN annual meeting several years ago, and I might have even scared you. I like chased you up off the podium, and I was like, "Oh my God, I'm your biggest fan!" So it's so exciting to have you here, and such a thoughtful, really great conversation, giving us so much to think about. So thank you for that. And I'm going to let you have the last word. You know, if we're going to walk away with anything today, what would you most like us to walk away with, Nika?
Thank you so much, Jim and Manju, and everyone for this conversation. I would just say, just to respond to Manju, I love this topic. I do not consider myself an expert. I learn from all of you so much. And so please feel free to email me. I would love to be in touch. I think if there's one takeaway, it's hard to consolidate it down, but I think, you know, especially given where we are in the world right now, it's to listen to and trust people. I mean, listen to and trust people, and really listen, so that we can, and I think starting from that framework, we can help to re-engage people. I really believe that this is not just about PrEP. This is about transforming our healthcare system. Done a terrible against people and harm people for so long. And so if we can take this moment and this opportunity to re-engage people in healthcare, restructure the way that we're thinking about prevention and health and wellness, we will go so much farther. So moving beyond these short-term outcomes to thinking about how we can really take care of and engage people and rebuild trust feels like this is our moment, this is our opportunity to do that. So if PrEP can help us do that, I am 100% on board.
Beautiful. Thank you so much. I can't imagine a better way to close and on trust and building a sustaining trust. I think too many times all of us in some ways think of trust as transactional around a new product or around new research. But trust is something you do 24/7, 365, year in, year out, all the time, whether or not you have research in the field, whether or not you need information from people. How we listen and engage folks is constant, and we don't always, I think, do that for all kinds of reasons. So thank you for giving us that charge. I want to thank everyone for joining us today. I want to thank all the 400 plus people who registered. We're going to have a great recording for those of you who weren't here in real time. And for everyone here, a reminder, we will send out slides. We will send out the recording. We will collate all these wonderful links that people have shared and drop that in the email as well. And then we'll help facilitate any follow-up questions with Dr. Nika Seidman. So with all of that, I am going to officially thank Manju, my co-moderator, AVAC, all of you, and again, Nika, for a really great session today. Take good care.
Thank you.